happy to be the editor of that and serve the community by providing you with best evidence in the form of a textbook. So we're working on the next edition right now. We're starting to plan it. And so it's been a great journey and a great honor and a privilege to be a textbook editor. Although in my other roles, I'm one of the senior editors of the Cochrane Neonatal Review Group. And I teach a lot of evidence-based medicine. David Sackett, the founder of evidence-based medicine, he said, first thing you do is throw away your textbooks because they get out of date so soon and they represent a limited view of the truth. When we were training, textbooks were the ultimate source of knowledge. Sora used to read every line in the textbook and correct it and tell the editors to make a mistake here and so on. It was a wonderful proofreader. But nowadays, there's so much knowledge everywhere. It's coming at you. And I think we need a different approach to organizing knowledge, especially knowledge that's state of the art and up to the moment, but in a consumable way that busy clinicians can use it for practice. Because the amount of knowledge that's out there is overwhelming. And people don't know what to pay attention to, what not to pay attention to. So I've been wondering what the next evolution of a textbook would be. And maybe what I would really like to see is an online live textbook where suppose a study like the PLUS trial just came out saying budesonide with surfactant versus surfactant alone, no difference in outcomes. Immediately your online textbook would get updated with that knowledge. And you don't have to wait for the next edition. So I'd like to see an online textbook that's live. So the comments on Twitter recently were in two categories. One is there was a systematic review published with just one trial included. And the poster said, how can a Cochrane review have just one trial? And they make a big deal with the systematic review. The truth is that the systematic review, when you write the protocol for the review, you're not supposed to know what's out there. You have to be objective and come up with a clear clinical question. And then you do a literature search. You might find 26 studies, you might find 0 studies. And of course, you want to have reviews with a lot of evidence and data. But there are some Cochrane reviews with 0 studies. Those are known as empty reviews. And some reviews have only 1 trial or 2 trials. And it's a little disappointing, but those reviews are also important to show how scant the evidence is for that question. So you might think, oh, everybody knows a lot about this, but in reality, we don't. So those are important as well. There's also a lot of debate on which is more useful. Is it one single large trial that involved thousands of patients? Or is it a meta-analysis of multiple small trials, which gives you the most useful information? And there's some debate about that as well. Obviously, if the large trial is consistent with the results of the multiple small trials, then it's all pointing in one direction. But there have been examples where one single large trial with 2,000 patients in each arm completely found the opposite of what multiple small flawed studies showed in a meta-analysis. So there's that debate as well. You had a comment, Sora? Yeah. David Sackett, the father of evidence-based medicine, also says there are 2 kinds of knowledge, background knowledge and foreground knowledge. Background knowledge is what is a ductus arteriosus? When does it normally close? What are the hemodynamics during transition? That is unlikely to change with new knowledge. So textbooks are good for background knowledge, but they're not good for the latest treatments or the latest investigations because that changes, like you said. One of your points is also that there's a huge amount of information overload now. If you do a Google search, it's overwhelming, the amount of information. So we really need a good source where the information is pre-judged, filtered, easy to consume, and up to date. That's missing right now.
Similar to politics, isn't it? You tend to follow someone who's kind of thinking the same as you. So, like heuristics or.
Exactly, yeah. Yeah, so one of the problems with systematic reviews is many people see it as an easy way to get a publication. And in many fellowship programs, the fellows don't want to do research. So they say, I'll do a systematic review. They'll write a protocol and they'll fight to studies, create a systematic review. And there's two problems with that. One is people that don't have a lot of expertise in doing systematic review. And the other thing is updating the review as new evidence accumulates is hard because the fellow graduates and moves on, and they may not be interested in updating the review again. So we have to track them down and beg them to update it or reassign it to somebody else. In the neonatal review group of Cochrane, we just allow anybody to write as a review. We want to encourage people to participate. In other groups, like the ENT group or the airways group or the pregnancy and childbirth group, they'll ask you first, what's your experience? Have you done any courses on systematic reviews? And you have to earn the ability to author a systematic. So that's one of the concerns.
One of the reasons systematic reviews are proliferating is the requirement of your job to have a certain number of publications. And when you don't have, most of the esteemed journals no longer take case reports or unless it's a case series or something significant. So you need to either do original research or you need a systematic review. And this seems to be the easy route, as you rightly said. They're good in statistics and they start putting it in. You want to comment?
Yeah. What was the exact point again?
They're good in statistics and they just want to publish more systematic.
No, I think anybody who attempts to author a systematic review should undergo some training in how to do systematic review. And also, they should do some preliminary assessment of how many studies are actually there and not be completely blind going in. That way, you have a chance of addressing a clinically important topic, finding a reasonable number of studies, and ultimately generating an evidence summary that is useful to practice in clinicians. Nishat also asked about the Bayesian approach versus evidence-based medicine. I definitely am a big fan of the Bayesian approach, especially for diagnosis. And if you're interested, I can do an online talk about the Bayesian approach to making diagnosis using pretest probabilities, likelihood ratios, and post-test probabilities. And today we talked about diagnostic errors, but remember what we need is diagnostic excellence. So in your attempt to avoid diagnostic errors, you can't test every patient for every diagnosis. You have to be judicious and parsimonious. Otherwise, you'll be testing every patient for every condition in your attempt to avoid missing a diagnosis. So how do you balance the two? You need a Bayesian approach for that. Okay, I can share a personal anecdote. Many years ago, we had a baby with a pneumothorax. So I asked the resident to prep the child for a chest tube. I went and did something and I came back. We put in a chest tube. After I put in the chest tube, I realized that it had gone in on the incorrect side. What had happened was the nurse was trying to be helpful and she had flipped the baby 180 degrees so that we had better access. And after we put in the chest tube, I can realize I had like a sinking feeling, crushing feeling in my chest that it went in the wrong side. The baby was stable. And I had just come back from a conference where I'd given a talk on patient safety. So I can't tell you how horrible, even today, like when I'm talking about it, flashing back, I have some PTSD because I was the second victim. First victim was the patient. So because I had done a talk on safety and I was thinking about safety, I knew the correct procedure was to stabilize the baby, then go tell the family honestly what happened. So I called my colleague and then we put in a chest tube in the correct side and removed the incorrect one. And then the resident and I went down to talk to the family. And I told them we made a mistake. I'm sorry. I expressed remorse. And the mother just broke down. The father just looked away. He wouldn't talk to me. And I had asked my colleague, if the parents say that they don't want me to be the doctor, will you cover the baby? And I will take care of the other babies in the unit. And he said, yeah, no problem, I'll cover. Because I thought they might say, we don't want you taking care of the baby. I asked him, do you want me to hand off the care to a different doctor? And they said, let us think about it. I went back after a couple of hours and they said, no, we want you to continue. And then the baby did fine. The baby recovered and we got out the correct chest tube and the baby started feeding. And before discharge, I went back to have a follow-up conversation with the family. I kept talking to them every day. And I did all the things. I apologized, I acknowledged there was a mistake, I explained how it had happened, and I expressed remorse. I didn't offer to settle for a lawsuit. That's not my job. I informed risk management. They said, we'll see how it goes. Just before discharge, I went and met the family and I took the chest tube kit, all the equipment, and laid it out and explained how we put in chest tubes and how the baby had been flipped and how it went in on the wrong side. And the father was listening, the mother was listening. By then they had relaxed. The father said, I'm an engineer in IBM. We do root cause analysis all the time in engineering. So we knew it was a systems problem. We knew you're not a bad doctor. We knew there was something else in the system that was promoting this. So my wife and I talked. And we thought, see, this is an honest mistake. It's not from incompetence or from being careless. And we thought of all the doctors in the hospital, you will take more care of our baby than any other doctors. Wanted you and not anybody else to continue the care. That was like an absolution and a blessing, because I was feeling so guilty. And they were actually like forgiving me. And they were giving me like a benediction that we trust you. Because you don't want to lose that trust in your doctor. And the trust has to be maintained between doctor and patient. I'm getting a little emotional now that I'm talking about it. So that's my anecdote. The Commission expects organizations to do a safety culture survey every 2 years. What happens is they do the survey in most organizations, but they don't learn from it or they don't try to act on it. They just check the box. So what I would suggest is every unit or every department take the results of the survey, study it, and definitely I think in most organizations, there is underreporting of how safe it is to speak up. So if 30% of people saying it's not safe to speak up, you can assume that in reality, the percentage is 50 or 60%, okay, or even higher. Because most people in those surveys, some people will give you the answers that they think you want to hear. Some people will tell you the truth. So the best thing is to look at the qualitative comments, then go in front of the department and say, we have these numbers, we have these qualitative comments. We thank all of you for sharing these honestly, and we are committed to changing the culture. I'm not guaranteeing that will change overnight because it requires all of us to weigh in on this, all of us to work on this. But you have to show that you listened. You have to show that you're going to make an attempt to change the culture, and then you have to actually make the actions. And once you demonstrate some actions, then people will start believing that you mean what you say. I'll give you another anecdote, brief anecdote. There was one doctor in gastroenterology who was having some performance issues. I was a little annoyed. So one day I was going to get coffee. I saw him in the elevator. And I said, I want you to talk to you. And I just gave him direct feedback that X, Y, and Z, which he's doing, is not acceptable. So later on that evening, I was talking to his division chief. And she told me that, the doctor you spoke to outside the elevator, he was very shaken by your comments. And he was going in to do an endoscopy and he felt very perturbed. Initially I said, I don't see what the problem is. There was a performance issue, and I just told him directly, what's the issue there? Then I realized that the division chief is speaking up to the department chair, who is her superior, and criticizing him for being too abrasive in giving feedback. And I said, I need to respect that. So I turned off that defensive mechanism. And I said, thank you for pointing out how I should have done it better. Then I said, why don't we call the doctor right now? And I'll apologize to him. And we called the doctor and we got him on the phone. So we had a three-way phone call. I said, I apologize for telling you those things outside the elevator. I should have done it in my office. I should have called you, set up an appointment, and given you feedback the proper way. And I'm sorry I did that, and I'll try to do better next time around. And I told the division chief, thank you for speaking up and telling me. So hopefully that action will reassure both of them that it's okay to speak up and say something negative about me. And that will create a positive feedback cycle that they will give me more and more feedback. Now, everything that they say, I cannot do. They'll say, oh, you're underpaying me. My salary is very less. I'll say, yeah, thank you for sharing your concerns. But I can't increase your salary by 20% right now, right? But certainly things like communication, listening, teamwork, and being courteous, I can change without any dollar cost. So I'm happy to listen to that. Best defense against medical legal accusations like that is to have a unit guideline, follow it, document it in your chart, and explain to the family that you're doing all these things. Even if you do everything 100% correctly, sometimes there will be non-preventable adverse events and you may get allegations. But you have the best defense possible. So beyond that, you can't do anything. And it's the nature of lawsuits to find sources and evidence that support the opposing party's claims and undermine your position, right? That's the nature of legal medicine, legal proceedings. So again, when I practice, I never try to practice based on how I might get sued. I always try to get the best evidence, have a unit guideline, follow the unit guideline. If I deviate from the guideline, you should document why you're not doing it. Document. Explain to the team and explain to the family, and then keep your fingers crossed and say a little prayer.
Obviously, in the court, you would be still supported because you have a credible source of information which supports the dosing. You're not catching it from most of your customers. But coming back to the same question of different evidences being available, a parent like Dr. Anwar raised a question of BPD, and we know that unclosed PDA in 24-week could come back to it with BPD later on or pulmonary hypertension. And the late closure is not going to help you, but at the same time, you must be seeing all the controversy, the different studies showing PDA doesn't need treatment. So if you do follow the school of thought which says no treatment, and then the parent reviews the Patrick McNamara is saying on 24-week you close it by skipping early, you have two schools of thought. You may be right by checking which one you believe, but what would be your stand in terms of how to answer the parent? I mean, you can't really go back at the future. You don't have a mirror future.
Yeah, again, my answer is the same. You should have a unit consensus about how you will close a PDA or when you close a PDA. Put it in a written guideline and follow that. It doesn't matter what other experts say. You can always find an expert to say what the opposing lawyer wants or what the parents claim. So we can't practice out of fear, though. I think we have to pay attention to cases like that and see if we need to change our unit policy or inform the parents in some way. But at least I do try not to practice out of fear, wondering where the next hit is going to come from. It's a paralyzing way to practice. Just have good insurance and do the right thing and document it. But yeah, definitely not informing parents about the risks of formula is something we can improve. And maybe we can introduce some written material. But then what happens is, on admission, the mom has just had a C-section. The dad is sleep-deprived. We give them like 6 consent forms to sign, one for PIC lines, one for this and one for that, and one for formula, and they just sign it. Is that really informing them or helping them? No. My ideal vision is to have an online textbook that is updated real time as new evidence accumulates. But we are very far away from that vision. So short of that, what I think is you need to have unit-based guidelines that all the attendings, all the neonatologists agree upon and build consensus. So if a new study is published in the NEJM with 600 patients in each arm, you need a mechanism to do a journal club, and you sit down as a group. So all 5 of you, or 10 of you, or all 15 of you, decide, should we switch to using paracetamol instead of ibuprofen from now on? Yes or no? Or should we use it in a subgroup of patients? Or should we not use it at all? You agree on it. Then modify your guidelines. The problem is, many people are not very skilled at critical appraisal. Many groups are not skilled at debate, healthy debate and consensus building. They become defensive and argumentative. And many people are very poor at making decisions in uncertainty. Because the thing that plagues all these decisions is uncertainty. If it's a very clear black and white decision, then it's easy to say, don't use it. But in a lot of these studies, there's a lot of uncertainty, wide confidence interval, or randomization was incomplete, or there was loss to follow up, or they only measured 18-month outcomes, not 5-year outcomes. So there's a lot of uncertainty. Decision making with uncertainty is the greatest clinical skill. Because if the decision is black and white, any fool can make a decision, right? But decision making in the presence of uncertainty is where you need critical thinking, consensus, wisdom, and judgment. So that's what groups need to develop. So I would see this as a group process. I remember very clearly once when I was a young attending, we did a journal club on prophylactic indomethacin to prevent IVH. Barbara Schmidt said. The fellow presented it. She did a beautiful analysis using critical appraisals checklists. And then at the end of it, I asked her, so do you think we should start using prophylactic indomethacin from tomorrow in our babies? She thought for a minute and said, I'm going to wait for the editorial to come out on this paper. Then I'll decide. The problem is the cast should be part of the manuscript. Like, why is the author putting a spin on the manuscript and then somebody else has to go and do a cast and clean it up, right? The editors and the author should do like an objective analysis of their strengths and weaknesses and say, yeah, we had a high loss to follow up, therefore our results are less reliable. Or 95% confidence interval is wide, so use our results with caution. But they don't do that. They always put a positive spin. So with the ideal manuscript, cast should be redundant, unnecessary, because the authors have done it themselves, right? But yeah, there is a definite role for a routine critical appraisal of every article published as a parallel process. As clinicians, we have to look at the outcomes of any study and figure out if that makes sense. One is when the outcome was measured. And was it just a change in physiology? Was it a change in actual functioning of the child? And did it lead to any long-term negative health consequences? So you mentioned composite outcomes, but there's composite outcomes and then there's competing outcomes. You said death or BPD. If you die at 32 weeks, you cannot develop BPD. So there makes sense to combine the two. But when you analyze the study, you have to figure out how the mortality changed and how the BPD changed in survivors. And then use your judgment in whether to use the results of the study or not. The other thing of this composite outcomes, where you may combine deafness, blindness, cerebral palsy, autism into one adverse neurodevelopmental outcome. There also you have to see how much weight you assign to each of those, because having unilateral deafness is very different from quadriplegic cerebral palsy. The second one has a lot more weight. You can't give the same weight to all of them. So you have to assign weights and use some judgment. But again, it requires insight, critical thinking, wisdom, some judgment. Okay. We used to do prophylactic surfactant. When the baby was born, we used to clamp the chest, not allow the baby to breathe, give surfactant, and then allow the baby to take a breath. That was overkill. That was way too much. Now we've become less invasive as a specialty. We're using LISA or even with LMA with the surfactant. It comes down to, again, critical appraisal. So if you really want to practice evidence-based medicine, translate research into practice, you need a few things. One is you need a good body of evidence. Then you need critical appraisal of the evidence. Then you need a process of reasoning through the pros and cons, whether you believe it or not. What are the benefits? What are the side effects and disadvantages? And then you need a way of coming up with a decision. You need all these steps. The reasoning is the most flawed of all these, because we were never taught. Did you ever get taught how to reason through a decision, like argument or debate or rhetoric? None of us were taught. So you take the evidence, you go through reasoning of the pros and cons. Do you believe the outcomes or do you not believe the outcomes? You really want to make a decision based on short-term outcomes versus waiting for long-term outcomes. And then you make a decision as a group. Again, the group decision is very important for neonatology because we practice as a group. And once the group decides, even if you don't agree with that, you have to stick to it. Trisha Gomella, who is the author of the book Gomella's Handbook of Neonatal Care, she told me once that when she was a fellow, in the fellow's office, there was a file cabinet with a folder with every neonatologist's name. On Monday, when the new neonatologist started, they would open the folder and say, okay, this person likes to use caffeine. They don't like to extubate very soon. And they like to use high CPAP when they extubate. They like to start feeds late and advance very slowly. On Monday, they would change this practice because every neonatologist has a different practice style. So neonatology is a team sport, and we have to sit around a table and discuss the evidence and come up with a consensus using our wisdom, experience, and reasoning without becoming defensive or without becoming confrontational. If you do that, then I think we'll all be better off in our practice.
We are running